I'll just start recording and we'll stream this to YouTube. I think we're good to go.
Great. Let me put my phone on airplane mode.
Okay, shall I make a brief introduction?
Yes, please, if you wish.
Okay, welcome everyone who are joining for this fifth episode of BreastCare Insights. We discuss different topics in terms of breast cancer and the newer trends, and also some of the well-known facts as well as those that are unknown to some of you, which would help in managing your patients. So today, it's a really interesting topic with somebody really interesting. Professor Amtul Carmichael is my guest today, who is a well-known consultant for me, who I've trained under and I've learned a lot from. She's a consultant oncoplastic breast surgeon from the University Hospital of Derby and Burton. Um, and Professor Amtul Carmichael has done a lot of work in this sphere of breast surgery and breast cancer. So the topic today is decoding risk factors and protective factors in breast cancer. Prof, over to you.
Oh, thank you very much. Thank you, Theekshana. Lovely to see you. And it is a very interesting topic, and it is something, the need of it, of discussing the risk factor and prevention of breast cancer could never be greater than what we have at this stage. So, over the next half an hour to 40 minutes, we will talk about some of the background understanding of breast cancer and how breast cancer developed, just a quick recap. And then we will look into the evidence base regarding risk factors for breast cancer and work out a framework of prevention of breast cancer that affects society and at individual and organizational level as well. I'm very happy to take any questions as you go along. It is informal chat with colleagues, but also I'm very happy to take any questions at the end. So let's familiarize ourselves with the background. What is breast cancer? What's the breast cancer burden at the moment? The latest figure regarding mortality for breast cancer are given here. The high colored area, which includes United Kingdom, Europe, have got very high incidence of breast cancer mortality. And these are relatively recent figures when we have access to better diagnosis, better treatment, better antisepsis, and better anesthetics. But Europe hasn't got the monopoly on poor mortality from breast cancer. We know from Polynesia and from some parts of Africa, the mortality for breast cancer is high. So just under 14% mortality for breast cancer worldwide is a cause for concern and should be a cause for concern for all of us. Let's talk about some myths. There are some myths that breast cancer is a product of westernization, globalization, and industrialization of the recent times. There may be an element of truth to it, but there is no evidence to suggest that breast cancer is a modern disease. We have evidence of breast cancer which is consolidated and lab certified of metastatic breast cancer in bones in Egyptian mummies. So breast cancer has been around for as long as women have been around on this earth, I should think. So it's a problem which, as a human race, we have not been able to solve. The other myth to bust is that with all the education regarding breast cancer and breast awareness and, and celebrating October as Breast Awareness Month and investing lots of time and energy on internet and leaflets for patients to know, the presentation of advanced breast cancer is an old times myth. No. This is a picture from 1828 showing an advanced breast cancer. And it is very sad to say that I have the opportunity to work in many parts of the world, and I've seen that in the United States of America. It's regular practice in my country, United Kingdom, where I work, to see women with very advanced breast cancer at least 2 or 3 times a year. And when I have opportunity to go and work in Pakistan, I see the same. So one, we have a big problem. Second, we have a problem which has been there for a long time. Thirdly, we have not addressed the issue of late presentation of breast cancer amongst all the women across the world. This is a busy slide, but just to familiarize yourself regarding the diagnosis of breast cancer going from 3,500 BC to more recently, this type of information is readily available at the Harvard Education. So it'll be interesting to sort of understand how breast cancer treatment has evolved. This is the first mastectomy, as we know, properly documented in 1600s, and this patient survived breast cancer, probably and breast cancer operation. We know that women had mastectomies using these gadgets, which were gradually tightened to reduce the blood flow to the cancerous part of the breast and perhaps to reduce the blood loss at the time of mastectomies. Mastectomies were done in patients' kitchen table with their family using the buckets and pots, and there was no antisepsis and there was very little anesthetic available to these women. So we are very grateful for all the advances in breast cancer management, and perhaps the whole-state mastectomy is the firm foundation stone of the modern treatment of breast cancer. The types of breast cancer have become important because of the treatments and various types of treatments available to us. We are all familiar with the basic ductolobular unit and the changes in the epithelial cells, which make cell hyperplastic, with atypia, carcinoma in situ, and invasive carcinoma. Perhaps what we did not focus on was the tumor microenvironment, the luminal cells, the myoepithelial cells, and the activity in the basement membrane. These were considered silent partners in epithelial cells, but as our understanding of breast cancer is improving, we know that these components are important not only in the development, but also in the outcome and treatment of breast cancer. We still don't know what causes breast cancer. We still don't understand if it is a single progenitor cell which leads to development of breast cancer, or there are several differentiated cells which lead to different types of breast cancer. Perhaps this is where more evidence is in terms of random mutations from a single progenitor cells. When random mutation happens, there's a pathway that is established for cancer cell to take its pattern of presentation at the time of diagnosis. However, we really don't understand and it must be frustrating for all of us, what causes breast cancer, because that would have helped to prevent it happening. We're all very, very, very familiar with the histological subtypes of DCIS and LCIS and invasive carcinoma. And traditionally, we have ductal carcinoma, no special type, a lobular, which could be classical or pleomorphic. And we also have seen rare invasive carcinomas, which we have mentioned here, tubular, which is associated with the best outcome, and medullary, which is associated with the poor outcome of breast cancer. But when we are looking after women with breast cancer and planning their treatment, perhaps a clinical subtype is more helpful. So the commonest form of breast cancer is the one which is ER positive and HER2 negative. This cancer tends to be of low grade with low Ki67, which is a marker of proliferation, as you know, and it has a low genomic expression score. So this still is the commonest form of breast cancer. This is the cancer we pick up at screening regularly and easily treatable and associated with good outcome. Second form of breast cancer is when it's still ER positive, however, and HER2 negative. However, it is high grade, which is grade 3, and may have high Ki67 index. These tumors have high genomic expression and hence are high risk and associated with poor outcome despite being ER positive tumor. Most feared breast cancer is perhaps triple negative breast cancer, which is high grade, high Ki67, and they have basal-like features, and hence they are associated with poor prognosis. However, these tumors can be treated very well with modern chemotherapy. And then there are rarer or other types where patients have breast cancer and they could be luminal or basal type with different types of hormone receptor. And this classification is very helpful because we find that it will not only help us with the treatment, but it also help us with the survivorship of the patient. Most of these patients have much lower risk of developing breast cancer recurrence or metastases. So hence, these patients perhaps could be managed long-term in a different way than those with triple negative breast cancer or triple positive breast cancer, where the risk of recurrence is likely and they may have more closer follow-up. And the modern understanding about tumor microenvironment changes, which make a tumor more amenable to intravasate into a blood vessel and metastasize and become drug treatment resistant to treatment, is becoming clearer. We are developing greater understanding of how tumors morph, and this is, but understanding, despite being quite advanced, is quite incomplete. So having just recapped about breast cancer, what are the risk factors for developing breast cancer? This sort of summarizes all the breast cancer. Some of these are very obvious, so we won't discuss them in great detail, but others we will have a little discussion about and see how we can make patients' life, women's life easy by addressing some of these risk factors. Age. Older you are, higher is the risk of breast cancer. I find this information very helpful in the clinic when looking after young women in their 20s and early 30s, the health anxiety people and people who have got very, very worried well women. And these kind of numbers are very reassuring. But as you can see, this number is very different from this number. So older a woman gets, that increases their risk of developing breast cancer. And we have got this fantastic paradox in the United Kingdom, where at 70s, when women have the highest incidence of breast cancer, we stop screening them routinely. There are economical reasons for that, but that's the important thing to say, that there are patients, as women get older, the risk of developing breast cancer gets bigger. And of course, we all know that's because of the multiple divisions of the cells and dysfunction of the mismatch repair genes. We know that patient could have genetic cancer or they could have familial cancer. There are recognized genes that lead to increased incidence of developing breast cancer. When I started my surgical career, BRCA1, BRCA2 were the only ones which were up there. All the others were variation of unknown significance. But now P53, P10, Cowden's disease are all recognized to be high risk, high penetrance breast cancer genes, which means that if a patient has these genes, the likelihood of developing breast cancer over their lifetime is over 50%. When I started my surgical career, which was about 20 years ago, PAL B2 and CHEK2 was somewhere here. And in one career, during career lifetime, we have found that they have moved over to intermediate risk from low risk. So all these genes are associated with increased risk of breast cancer, a lifetime risk about 50% for BRCA1, BRCA2 associated genes, about 25 to 30% here, and about up to 30%. So this is the understanding. Not all genes are the same, but if a patient has abnormal gene, it's worth understanding that, because as our understanding improves, we can enhance the outcome of breast cancer. So abnormal gene or gene mutation is found in 10% of patients. And another 20% of patients have no identifiable genes, but they have a family history which suggests a familial pattern of breast cancer development. So about 30% of cancers that women develop have a genetic or familial component to it. Sadly, we can't choose the family we are born into. We can't choose our parents. So that's a risk we just have to learn to manage. We can't modify that. And managing this risk is becoming easier. We have access to genetic counseling. We have access to enhanced surveillance. And now we are able to offer women bilateral mastectomy and reconstruction with this type of outcome. And there is evidence suggesting that there is the risk of developing breast cancer after risk-reducing mastectomy is decreased by more than 90%, and very early survival benefit evidence is also emerging, making managing this risk quite achievable in vast number of patients. However, gene tests are expensive, breast reconstruction is an expensive operation, and globally access to it is not that easy. I like to spend some time on the more modern risk factor of dense breast. Dense breast is associated with increased risk of breast cancer. So classification is BI-RAD, as you know. Very dense is BI-RAD D, heterogeneous density is BI-RAD C. Breast cancer is easiest to pick up in the fatty breast because breast cancer is white and glandular tissue is white. So if there's less glandular tissue, we can pick up the cancer easily. However, in patients who have dense breast, a cancer may be difficult to visualize because it is overshadowed by the white glandular tissue. That's not the only challenge with dense breast. The other challenge is that women with dense breast have increased risk of developing breast cancer. They're not in high risk category yet, but they have increased risk of developing breast cancer. and use of further imaging like contrast enhanced mammogram, which can very clearly demonstrate the lesion, is becoming more common. And of course, abbreviated MRI is also a modality we use to follow a patient or do enhanced surveillance or enhanced screening, supplemental screening in women who have increased risk of breast cancer because of breast density. In the United Kingdom, on the National Health Service breast screening program, we don't offer women any more supplemental imaging yet because of dense breast. However, this is under review. However, in Europe and in North America, women with a dense breast are offered supplemental screening with abbreviated MRI regularly. Then let's talk about a problem which is just increasing. Up to 40% of all cancer cases are preventable because they are associated with overweight and obesity. This is a very big number. Postmenopausal breast cancer is associated with obesity. Worldwide, 2 billion people are either overweight or obese, and I'm one of them, but 800 million people are obese. These are big numbers. These are low-hanging fruits. If we can address these, we can reduce and manage the risk of developing breast cancer. This is not some kind of fantasy discussion that happens. There's very good quality science showing that obesity or increased fat or adipose tissue in the body is associated with inflammation as marked by IL-6 and TNF-alpha. It develops insulin resistance. It produces pro-inflammatory cytokines, and all these lead to abnormalities of cell division, leading to development of cancer. When people have increased fat level, the hormones in their bodies levels are increased. Aromatase inhibitor in the fat can, aromatase in the subcutaneous fat will convert androgens into estrogen, increasing the lifetime exposure to estrogen, which increases the risk of developing breast cancer. But that's not all. High environment of hormones promote carcinogenesis because it suppresses apoptosis, which is a programmed cell death. And these numbers are concerning. And these numbers are even more concerning. This is absolutely modifiable risk factor. The risk of dying from breast cancer is increased by 10%. And a second breast cancer increases by 14% by every 5-point increase in body mass index. So body mass index going from 21 to 26 not only makes one obese, but increases their risk of mortality by 10%. These are big numbers. If we can address them, we can have significant change in the risk management of breast cancer. Obesity goes with physical activity. There is very, very good quality evidence that most active women, that is in the top 10% of physical activity, have 10% less likely to develop breast cancer in women in bottom level of physical activity. In other words, women who are less active are 10% more likely to develop breast cancer. Women who are active, and by active we mean that they do 20 minutes of moderate intensity activity every day, or 30 minutes of moderate intensity activity 5 days a week, reduce the risk of mortality by a significant number, both all-cause and breast cancer mortality. The evidence that physical activity reduces the risk of breast cancer recurrence is accumulating, but it's not robust enough yet for a number presentation. This, again, good quality science behind it, showing endocrinological, immunological, and metabolic processes which may enhance the outcome of women who are physically active. The processes, again, are pro-inflammatory, insulin-like growth factors, insulin resistance, and some evidence regarding vitamin D. Women who are physically active, maybe they're more likely to be outdoors, more likely to have high levels or normal levels of vitamin D. And as we all know, women with low level of vitamin D are at increased risk of developing breast cancer. What about diet and nutrition? Finding a robust evidence regarding diet is very difficult. All of us, I think, understand that diet contributes towards development and prevention of breast cancer, but to capture and produce evidence which is robust is very difficult. I think the most robust evidence is about fiber intake. In Western diet, fiber intake is really low. And those who increase their fiber intake increase the risk of longevity by 13%. So, though there are lots of theories, but robust evidence is only available for soya and fiber. What about alcohol? Even a small amount of alcohol increases the risk of several cancers, including breast cancer. For breast cancer, there is no safe dose beneath which we can say there is no evidence, there's no relationship with breast cancer. Having said that, this statement has to be balanced, that cultures and societies where women never drink also get breast cancer. So alcohol is not the only risk factor of breast cancer, but it is an important risk factor for breast cancer that can be managed. The metabolite of alcohol is acetaldehyde. It's a highly, highly toxic metabolite which disrupts DNA synthesis and repair. And more cell division happen, more damage to DNA happens, and less ability of cells to repair themselves can cause development of breast cancer or any cancer. Acetaldehyde also leads to oxidative stress and reactive oxygen species, which are genotoxic. And of course, there are associated factors like nutritional and other lifestyle, which are present in patients or people who have high alcohol intake, which may contribute to development of cancer. Reproductive factors are not in our control at individual level, but we will discuss that perhaps later about how these are affecting breast cancer management, breast cancer risk, and if this could be addressed somehow. A menarche earlier than 13 years increases the risk of developing breast cancer in adulthood by 5%. An average age of menarche in Western world has come down to 9. 9 years old are having regular periods, they're having regular exposure to estrogen, and that increases the risk of breast cancer. Any delay in menopause from later than 51.5 years increases the risk of breast cancer by nearly 3%. Age of menopause was 49 about 50 years ago, and it has gone to 52.5 now in the Western world. So there are these risk factors of breast cancer. It may be diet, it could be nutrition, it could be exogenous hormones, but all these are adding to the 3 million expected cancers by the year 2040. Highly unpractical in the modern world, but if women have their first full-term pregnancy under the age of 20, that reduces the risk of breast cancer by 50%. And multiple pregnancies and lactation also has a protective effect because reducing the lifetime exposure of estrogen and no pregnancy increases the risk of developing breast cancer. So we have had this plethora of evidence. How do we communicate to people? How do we explain this to women so they can manage their own risk? I found this is a very helpful website. It has other factors as well, but this is an easy way to explain to women without putting guilt on them or making them feel that they have caused breast cancer to themselves. Women want to use HRT to manage their symptoms, so explaining to them that 4 extra cases happen to women who take HRT for more than 5 years. Explaining about the use of pill, so women understand that pill also lead to additional 4 cancers. And if a woman is drinking 5 units of alcohol, her extra risk, there are 5 extra women who will develop breast cancer. And perhaps for a behavior changing perspective, these are highly relevant images. Extra 24 cancer if BMI is more than 30, and 7 less women will develop breast cancer if they're physically active. So I think this is quite a good visual representation to make patients understand and help them make the right choices for themselves regarding managing their risk. Breast cancer is such a disease where risk factors for disease development are also risk factors for disease outcome, not all of them, but many of them. So if we invest into preventing or minimizing some of these factors, then we will also reap the benefit of better outcome. So let's spend about 5 minutes looking at the protective factors regarding breast cancer. There are protective factors according to King's Fund can have several stages. One is a primordial prevention, a prevention where we stop people developing risk factors. We can't stop people being born as women. We can't stop women being related to those who have got breast cancer. So those are non-modifiable risk factors. We can't do anything about that. However, we as a society can invest in green spaces, walking places, healthy diet, a culture of physical activity where women just don't develop the risk factors for developing breast cancer and they're not susceptible. Primordial prevention is responsibility for the government, for people in higher position. However, we are not exempt from it. As healthcare professional, it's our duty of care that we raise the awareness to people in the decision-making position so that they understand that prevention at primordial level will save a significant amount of economical burden later on when women are having chemotherapy inpatient as recurrent breast cancer. If that primordial prevention didn't work, then we go to primary prevention, where pathological changes are happening, but we can stop them progressing to the next level. And that's where we have example of breast screening. We know breast screening works for most people. And now we know how to refine breast screening by making it tailored to the risk of women, giving them active lifestyle advice, offering them risk-reducing medication, offering them risk-reducing surgery, and managing the second level of primary prevention of breast cancer. Then secondary prevention is important once women has developed breast cancer. Same factors, obesity, physical activity, will contribute towards secondary prevention. And then tertiary prevention is managing survivorship. And all these, we can play a role in all of these, but particularly in stage 2, stage 3, hospital doctors have a good role play here. whereas here we are dependent on our politicians and people and higher up making decision, and here we are dependent on our colleagues in palliative care and general practitioners. In the end, I'll leave you with this slide, which is openly available on the internet, about risk factors for developing breast cancer and how to limit. The most important risk factor modification is to be physically active, maintain a healthy weight, and limit the alcohol intake. Non-modifiable risk factors we can't do anything about, but we can manage them by early screening, early intervention, and preventative surgery. I'm very happy to take any questions.
Thank you very much, Prof. Carmichael. That was a really in-depth description of these important points with regards to protective factors and risk factors. Uh, we tend to get questions in our setup as well from patients about, they try to go back to causality once they come across a diagnosis. Have I done something wrong? Sometimes oral contraceptive pills or HRT are in the history. So the patients do come back to ask this question from us. So it's really clear some of those things that you've mentioned that probably help our clinicians also navigate through some of these questions. So let's. There are a few questions that popped up from the chat, as well as some of them come personally to me, as well as on the YouTube. Um, what's the impression about getting IVF treatment and the treatment that goes with it? I think there aren't any studies as such, to my knowledge, that's done on this particular realm. But if you can comment on that.
So there has been some hype regarding abortion and IVF associated with increased risk of breast cancer. I think Lancet ran a very good review paper about 5 years ago, and we have not found any evidence that the having abortion or IVF significantly increases the risk of developing breast cancer. And in our practice, even ER positive women, if they haven't had children, we offer them fertility treatment. And 2 years ago at Association of Breast Surgeons, data was presented demonstrating no, as long as the risk is managed, everything is treated in a very controlled way, the risk of breast cancer recurrence wasn't higher. And then there is evidence that women who get pregnant after the development of breast cancer also do not have any poor outcome as far as at sort of population level. So I think that's a myth that need to be busted.
Right. Thank you very much. And then there's this question about genetics. To shed light, obviously, about this. In our setup, we don't have, especially in Sri Lanka, Pakistan, some areas of India, you don't get all the genetics done for these patients, and some of those who are sort of warranted for that will not have access to those services. And when we have services, they might only look at certain obvious genetics, like the genes like the BRCA1, 2. But when we sometimes find, when we do the full genome, we get sometimes cases with PALB2 and ATM, etc. So with these moderate risk genetics, what is your experience at the NHS setup? How often do you do prophylactic surgeries, and are they tested often?
Okay, so women are given a choice, and in my experience of offering risk-reducing mastectomy for the past 10 years, women are very clear what they want. Some women definitely want mastectomy, and they are in their 20s asking for it, and other definitely don't want mastectomy. in the NHS, we have got a screening program where we offer MRI screening up to the age of 50. That's when breast becomes less dense and a 2D mammogram will become acceptable for them. So that's the availability what they have. And some of them have abbreviated MRI, some have sort of normal long MRI. So that's what we offer. So patients get given offers of MRI screening, or they get given offer of surgery. We haven't had a great uptake on risk-reducing medication. Our women don't want to take tamoxifen. Our women don't want to take Arimidex. We haven't had a good, even if we tried, because a lot of women don't like the side effects of hormone treatment. Secondly, you only take it for 5 years. So what's the point is how they look at it. After 5 years, I'm going to be sitting here again, not sure. Risk has come down, but it hasn't been eliminated. So it's very much of a choice. So I would have thought if contrast enhanced mammography might be a very good way for low resource countries to manage these women for surveillance, because it is almost as good as an MRI. The cost is significantly cheaper and contrast is easily available. So that might, even in low income countries, resource countries. So that might be one way to look at it. If you're going to do gene test, then I think good 37 panel test would be sensible thing to invest in. When I started doing, we checked two, but 10 years ago, 2016, check two was in the low group. And in one professional lifetime, I've seen it go up. So that makes you realize that there is an awful lot of learning we need to have. And if somebody's investing in gene test, then giving them the best possible for themselves and for the next generation, because by the time their daughters become adult in 20, 30 years' time, we may have a lot more available. So that is my view. I would invest in an NHS about 13 panel, but for the private sector, 37 panel test. And those women who don't want surgery, we give them annual MRI.
Right, thank you. There's this question saying, asking whether if breastfeeding is protective for breast cancer, uh, would there be any protection for a particular type of breast cancer? I think that's what the question means, whether if somebody is protected from getting triple negative breast cancer per se.
So breastfeeding and early pregnancy are not shown to be protective against genetic form of breast cancer. So those who have abnormal gene mutation, they don't seem to benefit from early pregnancy or lactational. Protection is across the board, but our understanding is not that advanced, because when you're doing epidemiological studies, the numbers are huge, but details are perhaps not as precise as you will do in clinical studies, small clinical studies. So we need to be careful for the protective effect of lactation. However, the main thing to understand is that breast cancer is the function of lifetime exposure to estrogen. So one of my bosses used to work out that the lifetime number of periods a normal woman has is about 5 times than their mothers and grandmothers, because they had 4 or 5 children. They breastfed children for each child for 18 months to 2 years, and they didn't experience periods in that time. And the estrogen that is in circulation during lactation and pregnancy is a much lower potency than a non-pregnant estrogen type. So protective effect is there, but to dissect the deeper effect of protection is we don't have the data.
That is very clear. I think this is a practical question. So there is this patient who has had two primary tumors in one single breast. She didn't have any other risk factors. Um, So she has finally had a mastectomy for the same side, and now she's requesting, can I have a risk reduction um, mastectomy for the opposite contralateral side? I've seen many times that symmetrizing mastectomies are done, but can you do this for risk reduction? Is the question.
Yeah, I think it's a very good question. It's a very practical question. And I entirely agree. When a woman is wearing 48D bra, it just being lopsided is very, very difficult. And there's some evidence emerging from qualitative study that women with huge big breasts have got much better quality of life, the best quality of life after bilateral mastectomy, because they just get on with their lives without having to worry about the clothes and the social side of things, or practical side of things. Um, for our unit to offer risk reducing mastectomy, we use a criteria. If you this paper from Manchester that we use, and the author is BASU and Naren Basu. They give a criteria in which we look at patients' age, their family history, their previous biopsies, availability, possibility of any atypical hyperplasia, breast biopsy. And then we go through the table with the patient. It's really, really very good exercise for patient if they're asking for mastectomy, to sit down with them, complete the form with them, and then this gives us a number. If number is over 30%, lifetime risk of developing breast cancer, in our unit, we are permitted to do risk-reducing mastectomy and reconstruction. If their lifetime risk of developing breast cancer comes under 30%, then we reassure them and ask them to come back if there's any change in their personal or family circumstances. And that protects us from doing unnecessary mastectomy, and that gives patient either a reassurance or an answer that they could, and sort of validate their or authenticate what they are asking for. So I'll strongly recommend getting that paper. If you haven't got it, I can send it to Theekshana, and then you can, we've just got a printout of that questionnaire. Anybody who wants contralateral mastectomy, I sit down and go through that paper with them, that questionnaire with them, and then show them the answer. And that, in my opinion, so in my experience, I haven't had anybody then insisting to have one if they can see in black and white their risk is low.
Thank you very much for that. Yes, then whoever that asked question can reach out. We can share the details of that paper. I think the last question, this is something that I've recently read up as well. Metformin. Somebody has asked, is there evidence for metformin to be protective?
Yes, yes. Okay, so metformin has lost its license, so it's really cheaper than anything else, cheap than water now. So what metformin will do would address insulin resistance. So it would increase insulin sensitivity. It will reduce inflammation associated with obesity, and it would help with other markers. However, what metformin will do will convert glucose into fat.
Mm.
It may help patient obese. So the modern thing that is currently going on UK is the studies on Wegovy and other weight losing tablets, to say if they can produce injection and tablets now, if they can contribute towards breast cancer prevention. So there is some evidence that women who take long-term semaglutide and other medications that help them reduce weight have lower incidence of breast cancer. However, we have to be very careful because this is drug company data. However, there is a scientific trial being planned for that. So metformin is good for those women who can't be physically active. They have got severe arthritis and obesity. That may have a role. However, you can't trump physical activity because there's so many benefits to it if they have lower limb difficulties, they can do activity with upper limb. If they have upper limb difficulties, they can do activities with lower limb. So 30 minutes of exercise, ideally in a green space, is the best protective factor for these people. But yes, metformin is thought to be helpful as well.
Thank you very much. My understanding is the same. I think there was a trial about MA32, as far as I remember, but that also failed to show a significant improvement. So therefore,
Correct.
most of the authorities are still sort of American as well as UK. They're not giving this as a chemoprotective kind of effect for breast cancer. Prof. Amtul Carmichael, thank you so much. That was really comprehensive, and I think we've answered most of the questions, and the others were covered in your lecture. Before we wrap up, is there any final thoughts for people who are joining live as well as who will be watching this recorded version on YouTube? Anything that you want to take away, the key points?
Oh, that's very kind of you, Theekshana. Thank you very much for the invitation. I thoroughly enjoyed preparing for this talk, and it gave me a reflection. I think is that we, from time immemorial, we have women suffering from breast cancer. We have the best possible treatment, and the treatment is draining our resources. That's the harsh fact. And other harsh fact is that treatment is making women disabled. They suffer from bad neuropathy, cardiac disease, and other significant life-changing problems in their survivorship journey. So if we could work together to help people who are in the position of decision making understand the investment in primordial prevention, effective screening, and then very good early stage detection, that will be a great service to patient. And lastly, we really have to provide women the opportunity to be breast aware and to have the confidence to present when they have breast symptoms, because every time we see a very advanced breast cancer, we have failed as a society to protect these women. And I'm very proud of all the progress that we have seen in the development of breast cancer and its treatment in the last few years.
Thank
Thank
you.
you.
Thank you very much, Prof, for joining this webinar and preparing your presentation and giving us this knowledge. Thank you for training me over the past, last year. So, and thank you, and hope to see you again, hopefully in Sri Lanka with one of these programs. Thank you.
Thank you. You take care.
You
Many,
too.
many thanks. Bye.
See you. Bye.
Bye.